Hi everyone, welcome to this roundtable. I'm just waiting for various people's audio to connect. For those of you that sort of have popped up already, if you can make sure that your cameras are on, because obviously it's much nicer to look at a sea of faces than it is to look at a sea of names in these little squares. I'm sure we've all been to a couple of Zoom meetings where that's happened. So Jules, Ben, Holger, I can see there that we've got someone sharing their screen.
That's not me.
No, whoever's sharing their screen. Roland, is that you screen sharing or?
No, I know.
Okay, whoever is sharing their screen, if they could maybe not share their screen. I'm presuming you didn't mean to do that. I can't actually see who it is. So, oh, Holger, I think it's you. Hang on, I'm going to see if I can. Yeah, so there we go. Perfect. So yeah, so Chris, Jules, Ben, Alan, etc. If you can all make sure that as I said, your cameras are on. Holger's the only one that actually has his camera on at the moment, other than Robin and Peter. So I don't mean to sound too tyrannical about it, but again, you know, this is a round table. You wouldn't, as I was saying to Robin and Peter before, you know, you wouldn't come to a live event and, you know, put a bag over your head. So if you can turn your cameras on, that would be appreciated. But I'll get on with it. So obviously welcome to the Trend and Impact Roundtable, Longevity Therapeutics. We're joined by Robin and Peter, who are effectively going to be sort of your hosts for the roundtable discussion. But I'll leave it to them to introduce themselves separately. Just a couple of admin points. If you have any questions, please do put them in the chat function at the bottom, and we can obviously, you know, get to those questions. If it stays as sort of the amount that we have, you know, also feel free to sort of, you know, jump in with a question. It is meant to be an interactive roundtable. It's not designed to be an intimate panel. So, you know, ask questions, have discussions, you know, do all those things that you would do if you were sat around a table, you know, with your colleagues and peers, etc. So enough from me. Robin, Peter, I will hand over to you. Enjoy the session, and I will see you all shortly.
Thanks very much, Becky. I just echo what Becky was saying, that, yeah, this is intended to be interactive. Do feel free to interrupt, either through the chat or through unmuting yourself. Robin and I look forward to sort of trying to get the discussion started, but really hearing as much from you as from ourselves. So I'm going to try and share my screen now. Sorry. Oh no. Sorry. I'm using a different account on my Mac than I'm used to. I've got to unlock my system settings. We should have checked this as we were chatting, Robin. Well, while I begin to chat, I should maybe just introduce myself. Robin, is there any chance of you sharing my slides?
Yeah, I can download it and give me.
I'll come out of the call and come back in, actually.
All right. Let's see. So while Peter is coming back in, let me do a quick intro to the panel, and then I can maybe I can just switch order, and I'll present my talking points. Then we can have Peter do his. So my name is Robin. I'm CEO and co-founder of Deciduous Therapeutics. Background in biochemistry, spent some of my career in iBanking, private equity, but recently, the last 13, 14 years, been working on different startup companies. Somewhat new to the aging space in terms of, you know, the last 5 years I spent looking at senescence, and 2 years ago, started a company around the idea around using the immune system to clear senescent cells. So that's my background. Peter, you got it? Okay. You're on mute. Yeah, we'll get there.
Right, sorry about this. Been doing this for a year, obviously, like the rest of you, and yes, every time, well, not every time, but more often than it should happen. Right, can everybody see a PowerPoint presentation?
Yes.
Great. Okay, so I think Robin was beginning to introduce himself, but yeah, so we're here to talk about how will longevity therapeutics impact population life expectancy. Happy to take the conversation wider or narrower than that. We have an hour window. We'll just see what the natural length is and take it from there. So briefly, who am I? I'm Peter Joshi. I recently founded an advisory company, Genomica, which brands itself as being about healthy aging, artificial intelligence, really trying to look at high throughput biological markers or phone markers or any sort of data that can sort of measure aging and then understand how to intervene in the aging process and understand causality in that context. My current main clients are Global Gene Core, where we're actually focused more on genomic solutions, and another startup, Humanity Inc., where we're very much focused on these ideas of biological aging. Until recently, I worked at the University of Edinburgh, where I was looking at particularly the genomic basis and the genetic basis of human lifespan and aging and all-cause morbidity. And before that, I worked at Standard Life for many years as an actuary, in fact. And so my role here is really to sort of act as the interface between the sort of the theory and the science and the practical impact on society and business. I think Robin was beginning to introduce himself. Thank you for doing that, Robin, as I struggled with the Zoom. Robin is the CEO and founder of Deciduous Therapeutics. I think Deciduous is a reference to the idea of senescence and the replacement of senescent cells in the way that trees' leaves replace each other every year. But Robin hasn't told me that. I'm just inferring that from the little I know. Previously, he was involved in another startup, Alzeca Bio, which was focused on Alzheimer's disease and a diagnosis in that context. Before that, Robin's been involved in venture capital funds and investment banking for startups. He's got a wide role in the community as well, focused on a particular project-based engineering program for high school students in New York City, San Francisco, and Palo Alto. He tells me that he's interested in cooking and exercise, as indeed am I. Okay, so I thought I would just sort of start off with a few primers to get our thoughts flowing, and then Robin's going to give us a little bit more background on the sort of work he's involved in. This is life expectancy at birth for England as Wales for the last 500 years. And it's absolutely fascinating. As a sort of, I have a somewhat of an evolutionary biology background, and it might have been tempting to look at an organism like humans and say, well, actually, the reproductive lifespan is about 40 years, and therefore they don't serve any natural evolutionary purpose beyond 40 years, and therefore it's not that surprising that the mean life expectancy is 40 years. That's what you might have said in 1850, and then look what's happened. It's obviously been driven by environment, the change since then, and it's truly remarkable. I was listening to UK radio only last week, and they were talking about if you published a newspaper only every 100 years, the news story would be, if we were to look back over the whole sweep of the last 100 years, that life expectancy has increased from somewhere in the 40s to somewhere in the 80s. Drilling down on that a little bit, what's caused that? Well, one of the things that's caused it that we don't talk about so much anymore was a huge increase in the improvement in mortality associated with birth, both of the infant being born and of the mother. And remember, a mother would have several children if she survived having the first and second one. And so it was a major cause of shorter lifespans in the past up to arguably the early 1950s. Corresponding sort of chart, this is looking at all-cause mortality in England and Wales in the UK. We can see how much that is driven down just over the last the last 50 years, particularly in the latter part of the 20th century. And one way of putting this, maybe that's easier to understand, is in that period, longevity was increasing every 10 years by 3 years. So in a span of 30 years, the total life expectancy was going up by 10 years, which is a sort of incredible number. As you can see suggestively in this chart, it's begun to slow down a little bit since then, and there's a lot of speculation as to whether the sort of trends that we saw before, the causes of those trends are now reaching their natural limit or not. This is some work that my PhD student at the University of Edinburgh did. It's quite a busy chart, but really we're looking at the disease-driven improvements in mortality. And the main thing you can see on this chart is a lot of purple and a lot of maroon. And that's basically saying that cancer in purple and heart disease in maroon have driven improvements in lifespan. And the second thing you can see is in each of those bars, if you look closely, there's a mix of dark, which is the rate of which people fell sick to the disease as measured through hospital admission, and light, which is the rate at which people at the same age recovered from the disease more than they used to. And so we've seen a very sort of equal contribution from cancer and from heart disease, and from improvements in people not falling sick in the first place, and then improvements in their survival. And I guess there's interesting questions. One model might be, well, maybe people just feel younger because your propensity to fall sick is less if you're young, and your propensity to recover from sickness is greater if you're young. So our study wasn't able to delve into those details too much, but that is the sort of effect that's driven those very dramatic improvements in mortality that we've seen in the UK and across the West recently. We also, I'm not going to dwell on this slide, spent a lot of time looking at the genetic causes of mortality. And basically we discovered that for common variation in genes, it looks like it's disease genes that are driving mortality. There doesn't seem to be an aging regulator gene that's got common variation in the human population, that if we can just turn the dial on, will result in longer lifespans. That's not to say that there isn't such a gene, but we weren't able to identify it by looking at 1 million people and the genetic variation amongst them. I'm very focused on aging. Age and sex, I guess, are the things that actually certainly, and I think many demographers think, is the first explanatory variables for things like mortality and morbidity. This chart is really saying that huge number of the diseases that we think of that are life-limiting, both in terms of health span and lifespan, are all strongly age-related. Roughly speaking, it's about every there's a 5% increase in falling sick from one of these diseases for every year that you age. And of course, if you're that 1 year older, having had that increased risk, your risk of dying of that disease is also correspondingly greater. And it's common across all these diseases, this effect of aging. So that's really where I wanted to sort of get the juices flowing and get you thinking about sort of some of the things that might drive population life expectancy in the context of therapeutics. I'm happy to hand over to Robin now.
All right, thank you, Peter. 1 sec. Okay. You guys can see my screen okay?
Yeah, it's great.
Awesome. Okay. Thanks, Peter. So so my name is Robin. I've done the intro previously. Email down here just in case you want to send me a nice Cinco de Mayo greeting. I'd very much appreciate that. So I'm going to talk a little bit about the prompt here was, are longevity therapeutics only for the wealthy? And so I heard this prompt and I immediately started thinking on my soapbox about how that was a crazy prompt and how that obviously wasn't the case. But then I started to think about, like, why would that question even be asked? Like, why would that even be a point of contention or concern? And I harkened back to one of my first starts when I was about 13, 14 years ago, and I was doing a glucose responsive insulin company to treat type 1 diabetes. And so we were presenting a way to have a smarter insulin as an alternative to the conventional insulin systems that require the pinpricks every day. And a very wealthy fellow came up to me afterwards and said, that sounds like a great idea, but I'm not gonna invest in this. I'm not gonna do this. And I go, okay, that's fine, but tell me why. And he goes, I'm gonna get an islet cell transplant. And I go, okay, that sounds super expensive. And he goes, yeah, but that's what I can do, and that's that's for me. So it makes more sense. And I go, well, interesting, but I'm not sure if it's going to work that well. And two, you're going to spend a ton of money on something that may or may not actually be useful. And so that's actually, I think, circled back for me why the question even comes up as to why some therapies are for the wealthy versus everybody else. So first, I just want to lay the groundwork. Is this actually an issue? Does this actually, are the people in the lower socioeconomic status actually have disease? And so the answer is overwhelmingly yes. And is it worse than people in the higher end of the spectrum? Certainly, right? So even at the lower end here, mid 50s, you get your first disease if you're at the lower end of the socioeconomic status. But then if you're in the higher end, it's about 70 years old is the average for when you start to get a disease or disability. Similar for life expectancy, mid 70s, you start seeing, the tail off here. Whereas in the higher end, it's about 10 years later, about the mid 80s. And so, yeah, it absolutely is a problem. Furthermore, at the lower end of the socioeconomic status spectrum, you're also seeing that the incidence of multimorbidities or comorbidities tend to be much more common. And so that's what you're seeing in this graph. When you're at the higher end, you tend to have a much lower incidence of having multiple comorbidities at once. Okay. So I'm going to talk in a moment about the path to figuring out what the solutions can be, but just even in a longevity therapeutics session, I don't want to make it seem like there's nothing that we can do in the absence of biotech to actually solve these things. There's education that matters, healthcare matters, the society you're in, the neighbors you're around, the friends you have, your overall economic stability, all these things matter in the context of health. And then two, if I had, $1 million for every time someone told me in the longevity space, all you have to do is fast, eat a plant-based diet and exercise, you'll be perfectly fine. I'd have hundreds of millions of dollars. So ironically, I say that tongue in cheek, actually, I do all those things myself. So I do think they work. I do think it's very valuable. I do think there's a certain part of our health that we can take under control ourselves. At the same time, just having a good lifestyle doesn't always equate to, long-term health span. So what's happening? I look at everything largely through the lens of the immune system. So what we know, pretty dramatically over time is that immune function tends to decline as we get older. And, at a certain point, we start to reach a threshold where the immune function, just can't keep up with the diseases that are taking root. When we're young, these things tend to, be pretty, pretty resolvable at young ages quite quickly, but, 40s, 50s, 60s, these immune functions tend to slow down. It's not that they go away, it's just that they tend to be less active and less able to take on the full load of disease or pathogen as we age, and that really opens the door for disease. And so basically what I'm saying here is, at some point, you reach a tipping point where your immune system becomes overwhelmed. And so the question is, if you're looking to solve the issues, in my view, the most exciting approaches or just basically use the immune system as a map. So what is the immune system doing as we age? Which immune functions are responsible for which types of diseases, and can we map it all together? And so I talk about the immune system because I feel like, there's a reason we all have an immune system that keeps us healthy and, and alive for a long time. And I feel like, the starting principles, first principles of treating disease, in a large way, always comes back to what is the immune system doing, And can we pinpoint when it's not when it's not functioning actively or at a level that's useful enough to prevent disease? And so my view is that the most exciting technologies would actually, even away from therapies, would be diagnosing a poor immune function. Because then I think then we start to understand where the issues are and which immune cell types can impact disease over the long haul. Okay. The second point I want to bring up is with the FDA, metabolic syndrome is just one example, and it's typically not thought of as a single disease, and maybe it shouldn't be, but at the same time, those with heart disease, those are more likely to have kidney disease. Those with kidney disease are more likely to have liver disease, and it goes on and on. So there's kind of this idea around these systemic disease, and I think multiple metabolic syndrome is a classic example of that. So I think the interesting approaches in the future will understand that there's a link between multiple tissues and organ systems that can go together, and if someone can treat that systemically or effectively, it could be one rock for 3 birds or 4 birds, or however you want to think about it. But I just think we need to be a little bit more broad in our understanding of how these different tissue systems actually work together, and how heart links with kidney, links with lung, links with liver. And so instead of having therapies that treat just one of these at a time, then you take something else for the kidney, something else for the liver, something else for the lung, possibly there are ways to do this all in one shot. And so I think that's a challenge in the field, but I also have seen some people thinking about this as a way to put forward better therapies that you'll take less of, but actually be much more impactful and treat things systemically rather than trying to focus on one tissue at a time. That won't work for all diseases. I'm just saying in the case of metabolic, which good portion of the world actually suffers from, that could be an interesting approach to go after. Okay, and then lastly, I just want to say, I think this idea around gene therapy and cell therapy is massively interesting. I'm always blown away by how intricate and intellectually stimulating some of the approaches around cell and gene therapies are, especially. My only view is that, if we're talking about cost, we're talking about accessibility, think about, not using a hacksaw when all you need is a chisel. So if you can do it with a small molecule, do it with a small molecule. If you need an antibody or a biologic, that's okay. If you need, if an antibody doesn't work, you need to get into gene therapy and cell therapy, I think that's fine too. My point is only that, sometimes beautiful science doesn't always equate to beautiful endpoints. And so sometimes we overthink the problems because we don't understand the underlying biology. And so my viewpoint is always, first understand the underlying biology. What is actually happening? Why is it causing disease? And then is there a simple solution? And if not, that's okay. But don't run past the normal solutions or the easier, more cost-effective solutions if those are actually useful in treating disease. There's been plenty of time to go after gene therapy and cell therapy in the future. And I think a lot of those approaches are massively interesting, and I'm sure a number of them will be massively useful. My point is that, sometimes if you just really get to know the underlying biology, you might realize it's more about scientific understanding than it is about how complex your solution is. Okay. So lastly, yes, socioeconomic status does associate with reduced health span in lifespan. 2, yeah, there's steps we can definitely take outside of biotech, trying to bail us out for our health. 3, I think you need to look at the immune system first when you think about disease and how effectively and where things are going wrong and how to use that as a starting point for treating. 4, I think single cell RNA-seq has really opened the door for us understanding pathogenic cells at a very granular level, and I think would all be wise, when we think about disease, to first look at single cell RNA-seq pathogens and just understand what is actually happening at the crime site. What is really going on here, and then use that as a roadmap to success in treating those diseases. And then lastly, this is my, because it's recorded, I'm not going to say it the way I want to say it, but I just think if we're not making therapies that are cost effective and accessible, then I think all of us are not doing our job. And so I think it's absolutely incumbent upon all of us to make therapies that can be cost effective, accessible, and useful to everybody, not just a select few. Okay. Thank you so much.
Thanks, Robin. Really, I'm just minded to open up the floor for kind of responses at this stage, and do feel free to put your cameras on if you'd be willing to do so. I'm not sure we've got anything in the chat. Has anybody got anything? you want to ask or tell at this stage? Chris.
Yeah, hi there. I'm sorry, I have a corporate background, but I'm not speaking on behalf of my company at all. I'm interested in the socio-economic aspect. So you talked about how I guess it could be more impactful for lower socioeconomic groups because of the comorbidities. But then I guess you also talked about the cost effectiveness, and I think in reality we're saying that it's likely that the higher socioeconomic groups will be able to afford these kind of treatments in advance of the lower groups. So is it likely to drive a widening of the sort of mortality improvements before it sort of allows the lower socioeconomic groups to sort of catch up in effect?
Yeah, it's a good question. I think it really depends upon what the modality is, right? So let's think about something out there right now. So you have statins out there right now. Anyone who wants to get a statin, can basically afford it at this point. It's a small molecule drug. It's pretty cheap. It's generic. It's highly accessible. And so and that was my point at the end is, I think if you go with small molecule approaches, typically they're going to be cost effective for everybody. If something has to be treated with a gene therapy or cell therapy, then you're looking at all kinds of challenges with reimbursement, the need, the cost, what insurers think about this. And so my viewpoint is, if it can be done with a relatively, low maintenance modality like small molecule, it's a great approach. Even antibodies, are challenging in a way. There was a PCSK9 inhibitor came out several years ago, wasn't reimbursed for a couple of years. And the reason is that it cost $14,000 for the insurance companies. And they said, we don't care, go take a statin, right? And eventually the PCSK9s had to come down to 7,000, 8,000, 6,000 per year. And then it started to fall into the reimbursement window. So my view is, it just depends what's made. But typically, if you think about any market, typically, if it's effective and it's cheap, it's going to win. And so I just think, I think we just need to be smart about, not going overboard unless the situation calls for it.
Yeah, I think it's going to depend on the nature of the breakthroughs as well, isn't it? Are there going to be a number of small breakthroughs that sort of cumulatively have a very strong effect? Or is there going to be some radical, expensive breakthrough that therefore is perhaps very expensive to start with as it comes down? And I guess it's for each of us to have an opinion on that. I don't know. I guess it's much a question for the audience, but certainly, Robin, you're welcome to ask. I guess, as I said, I mentioned before, I have a bit of a background in evolutionary biology. Do we think there are natural limits to human lifespan? If there are, what creates them? Or conversely, do we think the first ever immortal has now been born? And keen to hear everybody's views.
No. It's a very interesting question. I would say, geez, I was thinking about this last night. I think when I saw your questions, I would say there's a lot of factors outside of just health that could impact mortality, right? So, there's environmental factors, climate change, everything. So it's hard to know. It's hard also to know, like, at some point, would someone want to live forever if they couldn't live well? So it's never been about, I think, living 500 years. I think it's always been about living 90 or 100 years better than before, right? So it's impossible. I'm sure there's a way physically to live forever. And I know that there's a fair number of investors that want to do that and want to invest in things like that. I'm just not convinced it'd be worth it.
Mm-hmm. Mm-hmm. I think certainly that I don't think very few people want to live beyond the point where it's a worthwhile, meaningful life. And there's lots of limits on that. And I feel quite agnostic as to whether or not there is a natural limit. When you look at those graphs, as I was saying, you know, it felt like 40 was in some sense the natural limit to the average life, and then it just transformed. Can it continue to do so? Or some people say, you know, we look at the mortality tables, and I don't believe this personally, and we can infer directly from them that no one can live beyond 120. I'm not saying it's going to be easy or likely that everybody lives to 120, but it's just not clear to me if we continue to have the economic progress that I think has driven much of what we've seen in the past, and the medical progress and people taking care of themselves better, that we can't at least continue to see the levels of improvement that we've seen in the past 50 years for the next 50 years. It'd certainly be nice to see that. And as you suggest, Robin, it'd be particularly nice if that was accompanied by at least a corresponding increase in health span. Becky suggested that I sort of maybe just directly suggest to people if they wanted to contribute. So I'm just going to go through my screen. Or Hector, I see you've popped up on the camera. Is there something you wanted to say at this stage?
Yes, I would like to ask you guys if we can get some lessons now from the recent COVID pandemic in relates to longevity. I mean, are we getting some calls from nature that tell us that we should probably live better and in order to continue?
Yeah. So maybe I think Robin's the real expert here, so I would just give a couple of sentences of my context. It is remarkable how age-related susceptibility to COVID is. It's actually remarkable beyond the age of 40, how all of the factors that you look at map. So if your mortality risk as part of a pool is X, then your COVID risk is X. It seems to be attacking underlying frailty that corresponds to mortality risk that's strongly age-related, but as we know, it's also BMI-related, it's also sex-related, and so on and so on and so on. I've been remarkably struck by some graphs which are literally on top of each other of COVID risk and mortality risk that suggests that aging and frailty has defined that. Now, Robin may tell us that that's obvious for the immune system or wrong or whatever, but I'd be really interested to hear what your perspective is, Robin.
Yeah, I mean, it's a challenging question because I guess the prompt is, what do we take from this? I mean, there's so many like societal, like personal things you can take from it. So I'm actually just gonna answer this question by, talking about what I tell my daughters every day, and that's, one is, just realize your life was probably pretty good, and now this is different. So just appreciate whatever the good times you have first. Two, on the more biotech side, what I tell my kids, as a reach because they're very young, but I always tell them, like don't prepare for the average day, prepare for the tough days, right? And so I think a lot of what I think about is when we talk about our health, you don't need to be in good health every day just to get through the day, but when you get illness, when you get stresses, being in good health, I think is a great starting point, right? That's a good foundation to start off of. So there's obviously a very high link between metabolically compromised people getting worse or higher mortality rates with COVID, right? And so maybe they were fine before this, but it seems like they weren't that far from being taken down by something that other people can fight. Part of it is age. I think just as we know, the immune system is quite active. Kids seem to not be nearly as well affected as the age population. I think that's a direct immune correlation. So the question is, as you age, can you keep your immune system functional and basically useful and youthful as you get older? That's how I think about it. And that's there's only so many things you can do in the context of a day-to-day life that's normal and feasible without going overboard. So I just think always prepare for the tough days, not for the good days. Yeah.
Thanks.
Good question. Peter, one question you might want to lead on, as we talked about it a couple of days ago. this idea around what insurance companies should do or how they react to longevity therapeutics, right? So do you think insurance companies need to change their model? Or do you think the approach for insurance companies will be to basically incentivize trying to move away from longevity therapeutics if they don't fit the model? So is it that they try to beat everything away and say, let's not reimburse these things, or is it they just need to get with it and just change how they think about disease?
I think it's the latter. If I'm honest, as I highlighted earlier, my background was at an organization called Standard Life, and the name sort of gives away what it does. It says on the tin, sort of thing, which is to say it was life insurance rather than health insurance. That was my particular background. So I'll talk from the point of view of a life insurer to start with, but it's not really what your question's about. I think the problem that life insurers have, looking at something like longevity therapeutics, is that actuaries are very backwards looking. They look at the past and they just carry on drawing lines and fitting models, and they really struggle to understand the societal consequences of step changes that are yet to be obvious in their effect looking backwards. I think to move to your question, in the end of the day, health insurers are going to have to get with the program, and to be honest, are going to want to get with the program, because unlike a company writing an annuity that's payable for the next 50 years, where it could be catastrophic if everybody lives forever, if people are getting good aging therapeutics, they're going to be claiming less in the long term. And so as a collective of insurers, it's good news. It's really down to, and I come from a different country where we have a different health system, and it's public paid, but in a country where it's private insurers that are really picking up the tab at the end of the day, I think it's going to be really about, as you highlighted for PCSK9, if the price is too high, the insurers are going to resist it, no matter how much the pressure is from society, and the balance will end up, social pressure against insurer cost of claims in the following year. But as that price comes down, I very much want them to get on board. They should get on board. And I think at the end of the day, it will be collectively in their interests to get on board. I'm less familiar, as I say, with the details of the reimbursement systems and the limits, etc., in America, and therefore how it might work in practice.
Thank you. Yeah, I think to wrap up, I'd love to open it up to any audience questions, particularly your most heart-wrenching, controversial questions.
So, sorry, I see. Ben's posted a question in the chat, which I'll read out. Are you concerned about overpopulation and resource scarcity if longevity therapeutics are, especially, for example, if childbearing ages are extended or people are living longer? Is it your belief that societal governance in other areas such as agriculture, production, climate, housing, and land use, for example, will happen in concert with a growing global population? I'm sorry you couldn't join us by video, but that's understood, Ben. Okay, there was quite a lot in there, Robin. Do you want to start?
Yeah, I love that question. That's really best one. So the ethos of the question is, if we do this really well, will that be bad because there'll be too many people and therefore resources become scarce? I mean, it's the glass half full, glass half empty classical discussion. So the one side of it that I buy into is that if people are more productive, right? So if we're doing this well, we're not necessarily making people live 30 years longer. We're making them live 15 years better. And if people are living 15 years better, it also puts them in a position to contribute for longer in a more productive time frame, right? I think the first thing that goes, like everyone here has been sick, I'm sure, and you're just in bed, you're just you're completely you're just not you're not useful because you can't physically do it, right? And so I look at it from the other side, is that if we have more productive people and there's more of us being productive, that'll be good. I'd also say, I have a lot of faith in humanity. I feel like there's been a lot of challenges, going back many, many centuries. And I feel like we've always, it's been ugly at times, but largely we've been able to figure it out once it's recognized as a problem, and two, once people band together. So if resource scarcity is a thing, which it very well could be with too many people, then my belief is that we are smart enough to figure that out. And I don't think, I just think there's natural biological limits to these things. At the same time, I don't think, if people can, have kids later, and that's, obviously good now for given the shifting of the work lifestyle for everybody. I do think that we're smart enough to deal with it. So I see it as a good problem to have. Certainly it will be a challenge, but there hasn't been many things in this world we haven't been able to figure out once we, start trying to figure it out.
Yeah, I half agree with that actually, Robin. I think in terms of the capacity of the economy of agriculture to cope with this change, particularly as you describe in the context of that we've increased good life for 15 years rather than poor health for 30 years. That there is the capacity there, and technological change and so on, I think can come in, and at very least if the change is gradual. What I do fear is that the capacity of, bluntly, government and politicians to make the changes that are necessary in that context is often quite limited. The thing that, for example, I often talk about is that state pensions were introduced in the early part of the 20th century. And often, for example, in the UK, the pension age was 65 and people could expect to live to 67. We now in the UK have a pension age, I think, of 67. It's sort of varying depending exactly when you were born. And people can expect to live to 87. And yet the government has been really reluctant to have the conversations with society about the cost of that, in terms of taxes, in terms of social security contributions, or setting the expectation that many people are now healthy into their 70s and that people might have to work longer. And so I think there's sort of deeper changes in the way that we manage individual financial circumstances that I think individuals and governments have been reluctant to address. Their father retired when he was 62 and they want to retire when they were 62, for example. Stephen, thanks for your question. Robin and Peter, can I ask to offer some comments on the debate we're focused on scarce resources, on quantity or quality of life, particularly given the care challenges in many countries? So I think we've begun to allude to that in a sense, but I think it's nice to address the question directly, Stephen. In particular, this care question. So certainly, I guess we're not certain that these life extensions that we might continue to see will be accompanied by a health span extensions, and to the extent, for example, that I highlighted the issues with the financing of these issues, certainly in the UK, and I think across the rest of the world, the financing of the care system has actually been at the back of the queue compared with the other issues that I've said have not been adequately addressed. So I think there are big issues there, and I think I'm not sure I even have a suggestion of great financial products that would appeal to customers that would address them, let alone that a society and government are going to implement them easily. Robin, what are your thoughts?
Yeah, I think it's again a very fascinating thing to consider. It's probably the kind of question where I need like a glass of wine and I'd probably have a better answer in 20 minutes. But so the question is, do we live longer, or do we want to focus on resources on living better, if I understand correctly? I think it's a tough one, right? Because I think up until this point, we're really focused on extending. We're looking at numbers, right? So can we live longer? My view is living better is better than living longer. And I think it's better for the person. I think it's better for the family. I think it's better for contributing, to society. And so that'd be my view, but it's a very tough question because, I'm speaking that, very objectively without thinking of someone right now in my family who's at that age where it could go, either way. Of like, do we live better for a couple of years, or we try to just get as many years out of this as we can? So it's a tough philosophical question. I don't know how to answer it, but I would just say that typically I think, if we're being honest, I think living better is probably the win that we're going for.
Yeah, and it is so difficult. It is a moral philosophical question. It's certainly the amount of health care expenditure that occurs in the last 18 months of a relatively poor quality of life period is that's where the expenditure takes place. And yet, if it could be done earlier, we'd probably get a lot more benefit out of it. But clinicians in particular, I think and I can understand why, they have a sick, ill, frail old person, and they have a potential treatment for them, and they want to intervene. And it is a deep moral question as to what society and individuals and clinicians can do about that. So Hector supported Stefan's comment, which was, therapeutics are really important in order to live longer, but wouldn't it be more efficient to focus on a healthy life? If we were to invest in healthier lifestyles, wouldn't we achieve more, as if we invented all new kinds of diagnostics? And it's an economic context in the context of trade-offs.
These questions are getting really good now. So I fully agree. But there's a couple of buckets here I think to consider. One is, there's some diseases out there that are just completely not up to the person, right? Like, there's some things that are lifestyle driven, and that makes up a huge chunk of disease. With things like genetic disease, where you can look at it like autoimmune disease, it's nothing the person is doing wrong to allow that to happen. That's just how they're, that's just what is their, in a lot of ways that's what their fate is, and that's what will happen. So I've always have a soft spot for autoimmune disease and genetic disorders, and especially rare disorders. Because I feel like there's been nothing, the person hasn't actually done anything to have that disease. So then the question becomes is, can you trade off the things that are more focused on lifestyle incited diseases and focus less on that? And I guess you could, at the same time, there's it's a very complex issue, right? So sometimes people make mistakes in their 20s and 30s that lead to disease in their 40s, and so are we just saying we're going to not focus on those population groups, or do we try to do something to help them? And I think there, and my view is that there's got to be, in this case, two walls closing in. I think we need to do much more on lifestyle. I think a lot of us could all do that. And two, I think if we did that, we would be able to focus therapeutics on the areas of huge need that are, somewhat, basically gotten by people for no fault of their own. And I think that if you had more money going that way, I think those diseases would then be much more properly handled. So it's a challenging question, but if you ask any pharma company, where they're focused on, it's probably some level of metabolic disease, which largely may be treatable just by improved lifestyle. But to get billions of people to do that would be asking a lot.
Yeah, I mean, I'd echo your two walls metaphor, Robin. I think the difficult, I worked in a public health department at the University of Edinburgh, and I think that the core difficulty for public health scientists when you look at these late onset chronic diseases is how beyond increasing affluence do we shift behavior, because we all know the things that we should be doing. Many of us are doing it. Many people have, particularly, at least in my view, at the lower end of the socioeconomic spectrum, they don't have the time, the energy, the financial resources to action the things that they should be doing. I think it's less that I don't believe it's that they don't know, or are weaker willed than the people at the other end of the spectrum particularly. It's just that it is very difficult across the spectrum, but particularly if you've got very pressing, urgent needs in your life today, to sort of invest in yourself in the way that we all know that we should be in terms of diet and fitness, and just looking after oneself. So I think there is potential to nudge people, and I very much believe that that's what we should be doing. But I think it's not easy.
Yeah, it is. It's much easier to give them a pill than it is to tell them to go.
Well, yeah,
you know,
yeah,
run 6
and
miles,
you know,
eat vegetables, and fast for 18 hours. So
yeah.
that it's unfortunate because that would be great. That'd be a great way to take the edge off a lot of these diseases. But the reality is, most people are not going to do that unless they really, really have to. So we got another question here. Perhaps we need to spend more funds on cognitive frailty. Very few therapies have improved cognitive capacity in younger age individuals. Cancer therapies have been much more effective last decade for increased lifespan. So Judith, that's a great point to make. I fully agree. Having worked in the Alzheimer's space before, I can say that cognitive frailty is hugely challenging because of how variable it is to measure. And so there aren't a lot of good irrefutable quantitative diagnostics that can actually tell you if someone is getting better or worse. There are a number of biomarkers and tests you can take that suggest perhaps it is going that way, or perhaps it's leveling off. But these are very, very noisy types of diagnostics, meaning they just have a lot of variability. And so my view on this is, one, you're absolutely right. Two, having worked in the space, I think the first thing to look at is, can you just develop really good, irrefutable, quantitative ways to diagnose how frail or how cognitively compromised somebody is. And from that, then I think you can build a case for better therapies because you will just understand how to measure better. The last part of it is, you just need to know what to attack in the brain in order to enable better outcomes. So there's some really interesting approaches now with immune targeting approaches in the brain to basically have the immune cells waking up and going to treat and remove the junk or the amyloid or the tau that accumulates in the brain with Alzheimer's. And so I think those are really promising. The challenge with immune activation, obviously, is, sometimes when you're activating the immune system, it can be a bit willy-nilly. It can be, sometimes there's off-target effects. So I think you just need to understand how you're activating the immune system and how you're moving it. And if you're doing enough good to outweigh the bad or negative side effects. So that's a challenge. But the field is actually moving in that direction. So it's pretty interesting.
Yeah, and I might widen out cognitive frailty slightly beyond what we think of as cognition, that the brain as an organ is in charge of so much what goes on in the body, that I think that we shouldn't sort of separate mind and body in a sense in that way, that actually, your brain's controlling all sorts of systems around your body, all sorts of responses. And I think a big part of actually making us healthier in the long term is about looking after brain health in the cognitive sense and in that wider sense. Hector, sorry, go ahead.
I was just thinking, this is Judy Kelleher.
Judith.
I was just thinking, though, that there is a big difference, and I've looked at the difference between, say, muscle frailty and cognitive frailty. Those mechanisms are going to be very different. So I think it would be wonderful if you could say, I'm going to cure aging, but I think in reality, the differences between organs is always going to be massive. And I think too that I think we're going to have to think about reversing deficits. As you said, Robin, you don't always know that the frailty is deteriorating as quickly. So I think we're going to have therapeutics like neuron regenerative therapies, especially non-invasive regenerative therapies, to actually reverse deficits, not just try to stave off disease.
Yeah, that would be the holy grail. So I would be very excited if people were working on in that lens.
Can you check Neuronascent? That's the company I founded a decade ago, and we have a therapeutic to do just that, actually in the clinic.
Awesome. that is great to hear. I wish you all the best getting that through. That's exactly where the field should be going.
I don't know, in the context of Judy's question, if you'd like to talk a little bit about senescence and if you see a commonality between senescence across organ systems, or whether or not you're the expert.
Yeah, it's very interesting. I've been thinking about senescence many years before I started the company in senescence. So there's two rough types of senescence we see. One is caused by cancer, and one is caused by non-cancer, so DNA damage induced senescence. And so, interesting, what we see is that senescence in a non-cancer context seems to be pretty consistent. So the way we see senescence in the lung with lung fibrosis versus metabolic disease versus heart disease versus kidney disease versus things like osteoarthritis, those senescence cells have a very similar expression. And so, with our approach is that, we can actually treat many different senescent-driven diseases, of which there are, more than 10, with the same mechanism. And so obviously need to go into the clinic and prove that out. But the early data with the models we use actually suggests that the senescence is one area where in non-oncology indications is actually quite alarmingly consistent, even amongst very different types of disease classes. So, when I was talking about systemic approaches to treating aging and thinking about, how to hit multiple goals with, one soccer ball, senescence is one way to do that. So that's why we think it's interesting.
Okay, well, thank you, everybody. I maybe turn back to Becky. Becky, would you like to join us? Can I just thank all of you for some very good questions and then for having joined us at all in this session, which I've very much enjoyed. Becky.
Thanks, Peter. And just to reiterate, obviously, thank you to everyone for joining us, but a big thank you to Peter and Robin for obviously leading the discussion today. So thank you to everyone for their questions. Obviously, it goes without saying, hopefully you will all keep the conversations going off of sort of this particular Zoom roundtable. Do connect with each other and, help the community grow. That's, why obviously we put on these conversations and events for you. So have a lovely evening or morning, depending on where you're joining us from. I'm in London, so it's evening for me, but I know that's not the case for all of you. So look after yourselves, and hopefully we will see you all again soon. Thanks so much.